The next presenter is Dr. Sangeet Mittal. Is he here? Okay. And then Dr. Manish. Okay. Yeah.
Good afternoon all. This study was basically undertaken to see if there was a correlation between the aqueous humor levels of soluble factors and the macular edema resolution in patients with CNVM in neovascular ARMD. As we all know, age-related macular degeneration is one of the leading causes of blindness among the elderly age group and it has two types, dry and the wet form. The wet form is characterized by CNVM with exudative maculopathy and vision loss. Vascular endothelial growth factor is one of the most well-studied and potent factor driving the pathogenesis in ARMD, and this also served as the first molecular therapeutic target. Since then, there has been the emergence of several anti-VEGF agents, and now they have become the standard of care for these diseases. However, there is a subset of patients which does not respond and develops resistance to anti-VEGF. Studies suggest the involvement of alternate molecules and pathways which could be responsible for this. So basically, there is this subset of patients that we see in our clinic which responds quite well with a few anti-VEGF injections which complete resolution of the SRF. Well, there is another subset of patients with SRF which even after multiple anti-VEGF injections shows a very poor response over a long duration. Hence our study hypothesis to look at the factors other than VEGF which could be responsible for this macular edema non-resolution. There is a dearth of knowledge about these molecular factors which drive the pathogenesis and the treatment response in neovascular ARMD patients, and our study aims to fill this gap. So the purpose of this study was to determine the association between the soluble factors in the aqueous humor samples and the treatment response in CNVM in terms of the resolution of macular edema. This was a cross-sectional study. The aqueous humor samples were collected from CNVM patients undergoing intravitreal anti-VEGF injections. So the samples were collected at the time of intravitreal injection after a written informed consent and institutional ethics committee approval. All active CNVMs due to neovascular ARMD undergoing at least two consecutive intravitreal injections as per the standard of care was considered as the inclusion criteria, and all inactive scarred CNVMs, the treatment naive and other CNVM pathologies, recent surgeries, lasers, diabetes, other causes of macular edema, and systemic diseases which could confound our results were considered as the exclusion criteria. Clinical parameters such as the central subfield thickness and the retinal volume was measured with the spectral domain OCT with the Heidelberg Spectralis software, and reduction in the edema volume was analyzed using the MATLAB image processing between the two visits. So the SD-OCT was done at the baseline and 1 month after the intravitreal injection. Based on this, the patients were divided into two groups. The resolving edema group, which was defined as a decrease in the central subfield thickness by more than 50 micron between the two visits, and persisting edema group, which was decrease in the central subfoveal thickness of less than 50 micron between the two visits. So after the aqueous humor samples were collected, they were stored at -80°C and are further being processed. The selection of the soluble factors was based on previous available literature. So cytometric bead array was used for the quantification of 17 different cytokines and chemokines. So once the aqueous humor sample was obtained, the cytometric bead assay was done for the simultaneous quantification of many different cytokines in very small samples. So first the sample was incubated with the cytokine capture bead, which was coated with a specific antibody to detect a specific protein, and this was further incubated with the cytokine detection bead, which is basically an antibody which is coated with a fluorescent material. So basically this complex gives a fluorescence, the intensity of which corresponds to the quantity of the cytokines in the sample. So the samples will be run on the flow cytometer. The beads come up in their respective alphanumeric positions, and the results are then quantified using the FCAP array software. So moving on to our results, it was interesting to note that the VEGF levels are actually very low in the persistent edema group as compared to the resolving edema group. This could probably be explained by the multiple number of anti-VEGF injections that would have been received by patients in the persistent edema group. Also, it was noted that the adhesion molecules such as the intercellular adhesion molecule, the vascular cell adhesion molecule and L-selectin were quite high in the persistent edema group as compared to the resolving edema group. It was also noted that the chemokine ligand 10 was also significantly elevated in the persistent edema group. So these factors, the adhesion molecules are in fact transmigration or help in the transmigration of leukocytes and macrophages, while this chemokine ligand is an angiogenic factor and it also serves as a chemoattractant. So basically, to summarize, the VEGF levels were significantly lower in the persistent edema group, and there was a significant increase in the adhesion molecules and the chemokine ligand in the persistent edema group as compared to the resolving edema group. This suggests that there could be a group of factors which could mediate the treatment response in these patients who show a non-response with anti-VEGF agents. It was also seen that there was a positive correlation between the lack of resolution of macular edema between the visits and the adhesion molecules and interleukin 2. The limitations of our study was a small sample size, and it was a cross-sectional study. It was not a prospective one. So AMD, as we all know, is a multifactorial etiology with a complex interplay of genetic, environmental, angiogenic and inflammatory factors. Several studies have been directed towards identification of these soluble factors, and previous studies have also shown the soluble factors' responsibility in diabetic macular edema. However, the association has not been studied extensively in age-related macular degeneration. So transferring science to clinics, our current findings with high levels of certain molecular factors will be explored further for its causal role in rendering this resistant to therapy, and following which further evaluation of these soluble factors needs to be studied for its potential use as therapeutic targets. So a targeted therapy could well be the direction towards future
Doctor,
solutions.
you crossed the time significantly. I just want one question. At what time during the treatment did you do the aqueous humor?
The aqueous humor was taken at the time of the intravitreal anti-VEGF.
No. At what time during the course of the disease? That is, how many injections later?
Yeah. So the study design was such that we had collected samples from all types of CNM at all stages of the disease. The only criteria was they should have at least received 2 consecutive injections.
You have done the aqueous humor sample in patients who have already received a minimum of 2 injections.
Yes, sir.
You have not done any aqueous humor sample in treatment naive. That is, before the treatment was started, you have not done.
No, because basically we wanted to see the
It would
treatment
have
response.
been, no, I mean, I personally feel that has got a lot of relevance. Because in the initial stage itself, whether the VEGF levels were low and mainly the inflammatory factors were high. And that, I mean, that's one of the,
Yeah,
I mean,
basically because we wanted to study the
Yeah.
treatment response, so we included patients who are treated. And since this was an exploratory study, we have included all stages of the disease.
Extend the question from Dr. Giridhar. Did you study the effect of steroids in these patients? Because these are inflammatory.
Yeah, so steroids were not used at the time of the study, but once we got the cytokine assay, we had given intravitreal steroids. We had given a combination therapy with anti-VEGF and IVTA, and we found a positive response. However, since this was a cross-sectional study, we had not included that, but these are the preliminary results. We are actually moving further with the longitudinal study. Thank you.
Dr. Sangeet.
So we have to mark if it is time out.
Time out हो गया. 1 minute ज़्यादा ले.
See, if you exceed time, we cannot give a marking on that. So try to finish in time.
Because by giving excess time, we are giving excess time. I mean, that means you're getting a benefit. You're able to convey more information. So, I mean, because this is an award and they have mentioned here that time should be followed very strictly. So please stick to the time.
Thank you.
6 minutes allotted. He is showing one card. ठीक से दिखाओ भाई साहब. भाई साहब, ठीक से दिखाना.
Shall I start, sir? Good evening, everybody. My topic is safety and efficacy of povidone iodine infusion during vitrectomy and endophthalmitis. Intravitreal injection of vancomycin and ceftazidime is standard treatment of endophthalmitis, but almost 5% cases have vancomycin resistance. And primary surgery is indicated when intravitreal injections fail, but again recurrences are common and visual outcome is poor. Povidone iodine has diverse microbicidal action against multi-drug resistant bacteria, candida, viruses, and Echinacea, and it is also active against biofilms. It has got additional advantage of being low cost, absence of drug resistance, and rapid bactericidal effect. Topical application has been used extensively in prophylaxis of infections. Povidone iodine has also been used intraocularly. Trost et al. Have shown that ERG showed no abnormalities when intravitreal povidone iodine concentrations were less than 0.027%. And a Japanese study by Nakashi Zuko et al. In Retina 2015 showed that the 0.025% PI-BSS plus is bactericidal and non-toxic when used as irrigation solution in vitrectomy, and this was an animal study in rabbits. Then Otani et al. In International Ophthalmology has shown uses of 0.025% povidone iodine in BSS plus for interior chamber irrigation and found it to be useful. A pilot study was done in which 4 patients of postoperative endophthalmitis who were not responded to intravitreal vancomycin and DEXA had recurrence following vitrectomy, underwent vitrectomy with PI infusion, and 3 eyes recovered from more than counting fingers close to face vision after the second vitrectomy procedure. The aim of this present study is to study efficacy and safety of povidone iodine infusion during vitrectomy for endophthalmitis not responding to conventional treatment. It is a randomized comparative interventional clinical trial, and we got the ethical clearance from the Department of Research and Medical Education of the state. The subjects were divided into 2 groups: 10 eyes with endophthalmitis not responding to intravitreal antibiotics underwent vitrectomy with infusion of 0.025% povidone iodine in Ringer's lactate. And in group 2, 10 eyes with endophthalmitis not responding to intravitreal antibiotics underwent vitrectomy with plain Ringer's lactate. A comprehensive preoperative examination was done, which included endothelial cell count whenever it was possible and electroretinogram in the form of B/A ratio. A postoperative assessment was done at 1 day, 3 days, 1 week, 2 weeks, 1 month, 3 months, and whenever required afterwards. Endothelial cell count and ERG were repeated 1 month after surgery. Patients with pre-op B/A ratio less than 1.0 were not included in the study. The toxicity to the retina was evaluated using the technique described by Payman et al. In Retina in 2006. And in this, the patient was dark adapted for 30 minutes after pupillary dilation. Unipolar contact lens was placed in the eye to be evaluated. Negative electrodes to the forehead and ground electrodes to the earlobes. The responses evaluated were dark adapted, scotopic response, scotopic flash response, and photopic response, and average of all these responses was taken. Difference of A and B waves was calculated for each step, and baseline was compared to response 4 weeks after surgery. Decrease in post-vitrectomy response greater than 30% was considered significant. Surgical steps included standard 3-port pars plana vitrectomy. PVD was induced in all cases. Endolaser, membrane peeling, silicone oil was used when necessary, and intravitreal vancomycin and DEXA were given at the end of surgery in all cases. And this is how this was prepared. 2.5 ml of 5% weight by volume of povidone was used, and it was added to 500 milliliter of Ringer's lactate, and this made the 0.025% povidone infusion. And this was prepared just before the surgery because povidone itself has got a short life. Observations, there were no significant differences on both the groups, except that the recurrence was seen in 3 out of 10 patients in group 2, that is only Ringer's lactate, and none of the patients showed recurrence in the group 1, that is povidone iodine and Ringer's lactate. Other factors like endothelial cell count after 4 weeks was comparable in both the groups. And none of the eyes studied in both groups showed a significant decrease of 30% in values of B minus A wave. And maximum decrease seen in group 1 was 14.53%, and in group 2 was 17.34%. Limitations of the study was multifocal ERG could be a better tool for evaluating central and peripheral toxicity. Our study had a very small sample size, so complications may have been missed, and endophthalmitis itself may have affected the ERG findings, so toxicity needs to be evaluated in other cases other than endophthalmitis also. To conclude, povidone iodine did not appear to be toxic to the retina or cornea when used in vitrectomy infusion. Povidone iodine 0.025% infusion during vitrectomy may be beneficial in control of infection, especially in patients not responding to conventional treatment, but larger and longer studies are required to establish the efficacy of this method. A small video just to highlight, just to demonstrate that the coloration by povidone iodine does not hamper the view that you get during the vitrectomy, and you can do even the finer steps. Like in this patient, you can do a PVD induction. We could remove almost all of the vitreous. We can even we could even peel the ERM after removal of the vitreous. After the vitreous had been cleaned, the fluid gas exchange was done and intravitreal injection was given. And this is 3 months post-op. The patient had a good vision of 6.9. Thank you.
Essentially, this means that you, because you said not responding to conventional treatment.
Yes.
So, two questions. One, you exclude those cases which would require vitrectomy, primary vitrectomy, right?
So the second part of the study was with primary vitrectomy only, not responding to the intravitreal antibiotics.
But that isn't, okay, if we talk about primary vitrectomy, it is primary vitrectomy with injections.
Yes.
So, how did you exclude, what were the criteria for excluding those cases which required you, according to you, primary vitrectomy?
So in this series, in this series, after the first 4 cases that we used that were not responding to even vitrectomy, and when we found that we are getting a good response, then we designed the study in which we did all cases, even primary. We gave the intravitreal injection first. If they did not respond to the injection, then we went ahead with the vitrectomy, and those patients were then divided into these 2 groups.
No,
How long did you
no.
after the injections?
48 hours.
No, the thing is that as far as the study is concerned, very interesting. I mean, there's no doubt about it. Very interesting. But then there are so many other factors that are, factors that are, it's very difficult for you to do have 2 groups, one as controls and the other one where you have got sort of virulence of the bacteria, the severity of the infection. So there are so many other factors that are implicating in such a situation. Therefore, it's very, very difficult unless, and I don't know the sample size, basically 10 and 10. So it is, probably the take-home message will be that it doesn't do any harm.
Yes, sir. It's
Number
not
one.
toxic.
It may have some antiseptic effect.
Yes, sir.
Okay, number 2. So probably these are the 2 important take-home messages, but then we can't categorically say that this is definitely having it definitely has a positive effect.
So
in
larger
case of,
studies needs to be done. On this.
So from that point of view, I think definitely we can say that this is a very, good idea. Idea is good.
Thank you, sir.
The variables are too many.
Yes, sir.
Whether after silicone oil injection, you injected silicone oil also in some patients.
In some patients.
You are giving intravitreal injections after surgery in all the patients.
In all the patients.
Yeah. So we don't know which is
Which is
working, whether it's iodine solution.
Or that is a limitation, but still we had in the group 2.
Only thing what we can prove is it's not non-toxic.
Yes, sir.
Did you see the bacterial profile before and after surgery?
Pardon, sir?
Microbiological profile before vitrectomy and after vitrectomy?
Most of the cultures came out to be negative after, because already we had given the antibiotics and then we had done, but most of the cultures came out to be negative. Because we don't have a proper lab follow-up, so we had to send the sample somewhere else.
Whatever video we are saying that it looks quite resolved endophthalmitis.
Pardon?
Whatever video we are showing, it looks quite resolved sort of endophthalmitis, right? Vitreous opacity is more. So whether
I
it
could-
was in a resolving phase of endophthalmitis or it was just
No, sir, they were active. They were not responding to the intravitreal injection.
to see the efficacy of the betadine, whatever it is.
Yes, sir.
Just we'll have to check the
So I can't comment on the efficacy, but safety definitely we can comment on.
Thank you.
Thank you.
Should I start, sir? So should I start?
Yeah, you can start.
Good evening, everybody. Today I will be presenting a novel cannula for
Just a second. The winner of the last round of Vitreo session is Dr. Dr. Ramesh Venkateshwar.
Now,
Yeah,
skip
you
out.
have to present.
What again?
Start counting now. Huh?
Wait, 1 mark, 'cause, yeah, I don't know. I don't think it's really necessary because basically we have heard you just now and we have marked it. And I don't know what.
Maybe other
Anyway,
audience may be
anyway, you
interested.
can come and present it.
May I start again?
Yeah.
Good evening, everybody. Today I will be presenting a novel cannula for vitreoretinal surgery, the aspiration scraper. Induction of PVD is the most important procedure in pars plana vitrectomy for many indications. So are the vitreoretinal interface procedures like ERM removal and ILM peeling. Most of the cases we use active suction by the cutter for inducing PVD. However, in some circumstances we have to use other instruments like ILM peeling forceps or diamond dusted membrane scratcher. Even with use of combination of instruments, sometimes it is difficult to induce the PVD and make life difficult for vitreoretinal surgeon. And then I was using a diamond dusted cannula for removing densely adherent cortex in a complicated cataract patient, which was an apple tree moment for me. If we stain the capsule in anterior segment and posterior segment, we stain ILM, we use Rexis in both. However, there is no instrument similar to bimanual cannula that we use. So, that is one way thought of aspiration scraper. It's a 25 gauge cannula, 33 millimeter in length, and has rounded tip, has a serrated handle for firm grip. There is diamond dusting at the tip and aspiration port on the under surface. It is connected to the aspiration tubing using using adapter in the constellation, which in turn is connected to the cassette. It can enter through 25 gauge walled cannulae easily, which may be difficult for soft tips and for the DDMS. Coming to clinical applications in cases of rhegmatogenous RD, here is a case, chronic RD, densely adherent vitreous. We are using cannula to gently scrape and aspirate vitreous at different points, and as the vitreous separates from the retinal surface, we see small hemorrhages appearing at the optic nerve head. Once adequate amount of vitreous is separated, then we can use cutter to complete the vitrectomy. Post-op follow-up. So this laptop is gone.
Charge gone.
Charge gone.
क्या भाई साहब क्या है चार्ज चला गया उसका
Okay. Good evening, everybody. Today I will be presenting a novel cannula for vitreoretinal surgery, the aspiration scraper. Induction of posterior vitreous detachment is an important procedure in pars plana vitrectomy, which is important for many indications, and so are the various vitreoretinal interface procedures like ERM and ILM peeling. Most of the cases we use active suction by the cutter for inducing PVD. However, other instruments like ILM peeling forceps and DDMS may be used in certain cases. In some cases, despite use of combination of instruments, it may be difficult to induce PVD and makes life of vitreoretinal surgeon difficult. And then I used a diamond dusted bimanual cannula for removing densely adherent cortex in a complicated cataract patient, which was a apple tree moment for me. We use stains in anterior and posterior segment surgery. We do Rexis in both, but there is no instrument similar to the bimanual cannula that we use in cataract surgery. So that was when we thought of aspiration scraper. It's a 25 gauge cannula, 33 millimeter in length, has a gentle curve and has serrated handle for firm grip. It has a rounded tip which is diamond dusted, and on under surface there is a small aspiration port, 0.2 millimeters. It is connected to aspiration tubing using the adapter present in constellation set, and which in turn is connected to the cassette when in use. It can easily pass through 25 gauge walled cannulae, which may be difficult for soft tips and for DDMS. Coming to clinical applications, this is a case of rhegmatogenous retinal detachment where the vitreous is densely adherent. We are using alternative scrape and suction function at various points to separate the vitreous. As the vitreous separates, we can see hemorrhages appearing on the optic nerve head. Once adequate amount of vitreous is separated, cutter is used to complete PVD and complete vitrectomy. This is post-op 2 months. In cases of chronic RD, vitreous is often densely adherent to the anterior retina. Here the blunt tip, we can use the blunt tip to get dissection plane between the vitreous and retina, and we can separate the vitreous and retina, and then cutter is used to trim the vitreous from the anterior retinal area. The post-op photograph of a patient who was one-eyed, it was vision improved from PL to 3 meters. In cases where sclerotomies are made using non-walled cannulae, the retina can get incarcerated. The blunt tip of the cannula can reposit the retina, and then the active suction can be used to aspirate fluid from a pre-existing break, thus avoiding retinectomy in such cases. In phakic eyes where the break is very anterior close to ora, the curve of the cannula makes it easy to reach the ora, and then we can drain the fluid without creating a posterior retinotomy in most of the cases. In macular surgery, in cases of vitreomacular traction, it is important to induce PVD gently. In this case, we are inducing PVD gently. This is important to avoid deroofing the macula. As the adequate amount of vitreous is separated, cutter is used at high cutting and low suction to complete the PVD and then complete the vitrectomy, so without deroofing the macula. This is the post-op photograph where the inner retinal layers are intact. In epiretinal membrane peeling, the blunt tip of the cannula is used to first initiate the ERM removal, and then we can scrape it to the entire extent of the membrane, and then alternatively suction and scraping function is used, so we can remove the ERM in non-touch manner. In this case, we had an excellent post-operative outcome. In patient with ERM removal, high myopic patients, we might be able to use the cannula because it is long axial length and it can be used. It can use to stain the ILM without causing jet. We can start peeling ILM with this and then tear it with the ILM peeling forceps. We can manipulate the flap into a macular hole in patients where there is we are doing inverted flap. In proliferative vitreoretinectomy, we can aspirate the clots from the retinal surface without causing any trauma. We can use it bimanually with the quadri to coagulate bleeders. So this is a versatile instrument which is often used as, it's a first multifunction instrument in MIVS. It's a useful accessory, reusable, useful in highly myopic eyes as well. It's a rigid instrument. There is a potential to cause retinal tear, and the movement has to be parallel to the retinal surface, and it has to be used in gingerly manner. I would like to thank these people, and thank you.
But my only concern is that whenever this instrument is being used as a substitute for DDMS,
Yes.
scraper,
Yes.
those are the situations where I am concerned. And you also said that since it's rigid, because you just cannot use this as a substitute for scraper in those typical circumstances.
No, this is basically another method by which we
If
can.
I can answer that question. Sir, this idea came to my mind when I was having difficulty in inducing PVDs in attached and detached retinas. In what we are doing in such cases with DDMS is that we are separating and creating pockets of vitreoretinal separation at certain points, and then cutter is used to separate it. What this further does, or this cannula does,
I am referring to those situations where DDMS is exclusively used.
correct. So this is one more method, and it has wide applications where DDMS is not useful also, like removing the clots from retinal surface in diabetics. It's useful.
Limited uses, that is the only point I want to make.
Okay.
It's means only thing what we can gain with this instrument is we don't have to interchange.
Yes, sir, exactly, because
That is the only advantage. We don't have any other advantage for this.
well,
And I think it needs a little learning curve also, because I feel the chance of iatrogenic breaks is quite high.
We have to. It's not very high, frankly speaking. In cases where I'm using in chronic RDs anteriorly, there is a blunt tip. On the contrary, when I was using cutter to separate the vitreous and retina, it is safer. I found it safer in those cases. But yes, there is a potential.
One
Yes, sir.
question, the tip of this opening of your cannula was not end on.
No, sir.
It's
It's
so
at
the
the under,
basic
sir.
problem we can use when we use the cutter. Many a times we are not able to engage the vitreous into the cutter because it's not end on; it's on the side. So does not it creates a problem for you, because when we induce PVD with an end on extrusion needle, then we get hold of the vitreous.
Can I?
Yeah.
So it was purposely not kept on the end on. It was kept on the under surface so that we can use the blunt tip to, it will not get aspirated into the blunt tip whenever we are using it for indications like ERM removals, and even in PVD induction, we can increase the suction very high because of small aspiration port. We can use the suction very high, and it is very easy or it's very safe because it doesn't suck into the cannula suddenly. If the tip is on the end on, it will suddenly suck the retina.
Does not it make a blind procedure in inducting
No
or
sir,
aspirating?
no sir, no sir, you have to
Because
use it.
it's below what you are seeing.
So once I have got separation between the vitreous and retina, then only I use a suction. It doesn't make it blind, and the suction port is very small for it to cause any significant retinal trauma. Thank you.
Good afternoon, everyone. In this paper, we shall describe the correlation of the retinal structure and visual acuity, okay, using the OCT and OCT angiography. We know that myopia is one of the commonest refractive errors worldwide and is characterized by axial elongation and scleral thinning. When we look at the stages of myopia, it affects the retina, the choroid, and the sclera in a sequential manner. The structure of the retina can be seen with the help of the OCT, the vasculature with the help of OCTA or the fluorescent angiography and the ICGA, and the visual function with the help of visual acuity or fundus autofluorescence. There are many papers which have actually spoken about the retinal structure with axial length, but they have given different results. On looking at the vasculature in axial lengths with myopia, there are various results in the peripapillary and the perifoveal area. And papers have also described the role of structure versus function in myopia using OCT and automated perimetry. The results of these studies are variable, and hence we thought we need to do this study to study the correlation between the retinal structure and vasculature with axial length, spherical equivalent, and visual acuity. In this process, we intended to measure the retinal layer thickness using the OCT, the foveal angle using the OCT angiography, and the vasculature using the OCTA angiography, and then correlate with the axial length, the spherical equivalent, and the visual acuity. 86 eyes of 45 patients were prospectively enrolled who met the inclusion criteria. Patients who where the retinal vasculature were affected, such as in cases of diabetes and glaucoma, were excluded, and in cases where the OCT or OCT angiography was not possible to procure, they were excluded from the study. After the history taking, the patient underwent regular ocular examination using with the visual acuity testing, the slit lamp examination, the applanation, and the indirect ophthalmoscopy. Axial length measurement was done using the optical low coherence reflectometer, lens star, and the retinal layer thickness measurements were done using the Spectralis automated segmentation tool, where the retinal layers were classified into 4 groups: the inner retinal layers, the outer plexiform layer, the outer nuclear layer, and the photoreceptor outer segment thickness. We used a 15-degree papillomacular bundle grid the protocol to measure the retinal layer thicknesses in this study. We measured the foveal angle using the image J technique, and the vasculature was measured in the 3 by 3 millimeter foveal centered scan, where the flow area and the vessel densities were measured in the perifoveal, superficial, and the deep capillary plexus using the AngioView software in the Topcon machine. Coming to the results, 86 eyes of 45 patients with a mean age of 33 years, an axial length of 26 millimeters, and a mean spherical equivalent of -7 diopters were included. When we looked at the axial length of 23 millimeters with a visual acuity of 20 by 20 and a spherical equivalent of 0, we found that the foveal contour was normal, it was deep, there was absence of inner retinal layers at the fovea, there were thicker outer layers, and the photoreceptor outer segment was thick. When we looked at the OCT angiography, the superficial capillary plexus was round and regular in the foveal avascular zone. There were no vessels which were crossing the center, and the regular whorled plexus was noted. The deep capillary plexus was also round and regular, and it had a regular filiform appearance. When we had a higher axial length with around 29 millimeters with a visual acuity of 20 by 60 and a spherical equivalent of -9, there we found that the foveal contour became more shallower. There was thickening of the inner retinal layers, there was thinning of the outer layers, and the photoreceptor outer segment was more thinner. And the foveal avascular zone in the superficial capillary plexus became more irregular. We had vessels crossing the center, and there was a broken whorled plexus. Even the deep capillary plexus showed a smaller FAZ. On examination, on statistical analysis, we found that as the axial length increases, there was thickening of the inner retinal layers and the thinning of the outer segment layers with an obtuse foveal angle. While with the increase in the axial length, the vessel density in both the superficial and the deep capillary plexus increased. When we correlated it with the visual acuity, we found that as the outer segment became more thinner, the visual acuity became reduced, and the vessel density and the flow area in the deep capillary plexus did not have a statistically significant correlation with the visual acuity. So we infer that in myopia, Where there is lateral stretching and anteroposterior traction, there is flattening of the foveal contour, there is thickening and persistence of the inner layers leading to increased vessel density in the deep capillary plexus, and there is thinning of the outer layers leading to reduced visual acuity. Our findings are supported by the fact that a similar feature was noted in patients with ROP and FEVR, where they had noted persistence and thickening of the inner retinal layers and increased vessel density. Both these diseases are associated with secondary myopia. So ours was a novel observation where we found that in abnormal myopic eyes, the retina became more thicker in the inner retinal layers and the outer segment layers became more thinner, and the vessels were very irregular at the foveal avascular zone. Our study had few limitations as well. It was a cross-sectional study. Instead of using the 15-degree papillomacular bundle grid, we could have used the ETDRS grid, and we did not correlate with the choroidal thickness on OCT. So the clinical relevance was structural changes in retina happen with increasing myopia, the foveal plana, the persistence of the inner retinal layers, and the thinning of the photoreceptor outer segment, they influence the visual acuity, and increased vessel density in the middle retinal layers do not have any influence on the visual acuity in myopia. Thank you so much.
All M I can. Thank you. Oh yeah, Majara. Already it is very late. They will mark it. They will mark it.